All right, so I'm going to talk about BRUEs, ALTEs. Everybody knows what an ALTE is, but no one knows what BRUE means. Why was there a name change? Should I call it ALTE? Should I call it BRUE? Residents coming in, they're like, I think he was choking. I think he just had a BRUE. We can send him home. So there's a lot of confusion behind what an ALTE is, what a BRUE is, and what terminology should be used, and what it actually means. And I want to try to demystify some of this for you guys, right? So this is the original definition of an ALTE. An ALTE is a acute life-threatening event, right? It's an episode that is frightening to the observer and is characterized by some combination of apnea, color change in muscle tone, and choking or gagging, right? And this definition has been used all the time, and for clinicians, for physicians, for researchers, this has been an extremely loosely defined term. It's you don't really know where to put conditions that fit these symptoms, right? And so based on this, for years we've had this problem to try to figure out, once you have a kid who's choking and turned a little red, what do you do with this kid? What is it? Is it an ALTE? Is it serious? Is it something you can send home? So, one of the biggest problems with this definition is that it's an episode that is frightening to the observer, right? And how often do you see, moms coming in with their kids this way in the peds emergency room, and this is what the kid looks like, right? And so what does that mean? So if this mom came in saying that this kid was choking and gasping and turned red, and this kid looks like a peach in the peds emergency room, what are you going to do? So because of these confusions, right? So this kid now looks good. What should I do? Researchers thought they need to change this. Another problem is that it's a life-threatening event. The term itself causes parents to feel like, oh my God, this is life-threatening. Like, what should I do? This is something that needs to be looked at, something that's dangerous. And a lot of times we just reassure them, oh, it was just a life-threatening event, and you send them home. And parents are, oh, that doesn't make sense at all, right? The fact that it was defined as an apparent life-threatening event means that it kind of makes physicians do unnecessary tests. It gets parents more anxious. It leads to more anxiety, more testing, more, which kind of makes it a little more difficult for parents and physicians. So based on all of these things, and most of the times, these acute life-threatening events, apparent life-threatening events, are just physiological variations of what kids do, right? So because of all this confusion, in 2016, the AAP, American Academy of Pediatrics, met, and they kind of recoined this definition and said that, let's call it a brief, resolved, unexplained event. And that's the definition we're going to use. We're going to get away from the term ALTE. So no one's using the term ALTE anymore. And the idea behind it is that they wanted to kind of weed out and separate events that could have a diagnosis, and they wanted to stratify those events that you really could not diagnose, into high risk and low risk, and kind of talk about at least some management aspects of that, right? So, for example, the new definition, which is BRUE, brief, resolved, unexplained event, is defined as a BRUE has occurred if an observer reports a sudden, brief, and now resolved, unexplained episode with one or more of the following: cyanosis or pallor, absent, decreased, irregular breathing, marked change in tone, altered level of responsiveness. So it's kind of similar, but not really. One of the biggest things that changed in this definition is that they added something called brief, resolved, sudden, and unexplained. So it is something that is transient, something that has now stopped, something that now is not continuing. So ALTE as a term, most of the kids that came with ALTE, right, looked good, but it wasn't necessarily something that was defined as, it could have been something that was still going on. So you had a child that maybe had a mild, hypertonia, change in tone, and came in and was still like maybe looked a little like sleepy, that could have been defined as an ALTE. But in terms of BRUE, that's not the case. The patient should have now come back to his normal state, right? So any patient that had these symptoms previously, which is now resolved, okay, can now be classified as a BRUE. BRUE is basically still a constellation of symptoms, right? And what the AAP tried to do is that they tried to just classify BRUE as those patients that you cannot diagnose as having a particular illness after complete physical examination. For example, you had a kid that maybe turned apneic for maybe 10-15 seconds and was rushed into the emergency room. And when you see the kid looks fine, except maybe has a little runny nose congestion, maybe has a few coarse breath sounds. It's December. So you diagnose this kid as maybe having bronchiolitis, right? The fact that you were able to diagnose this kid as having bronchiolitis, it's apnea secondary to bronchiolitis and not apnea secondary to an ALTE, right? You have a patient brought in who had a brief stiffness at home, and a little choking, gagging immediately after mom fed this kid, and this happens all the time. We all see this. Kid's now back is in the emergency room. Kid looks great, right? But you're not going to call this a BRUE. You're going to say that this kid most likely had a choking, gagging episode secondary to gastroesophageal reflux, right? GERD. So that's where they want to kind of try to differentiate between a BRUE and everything else that you can diagnose. So this is something. This is basically a flowchart, kind of trying to simplify what a BRUE means, right? So it's brief, right? So by brief, they define it as anything less than a minute, usually anything not lasting more than 20-30 seconds, right? So if it's not brief, it's not a BRUE, right? It should have resolved, so that you should have normal vital signs. The kid should be normally appearing. If on your presentation to the emergency room, the child does not appear normal, does not have normal vital signs, it is not a BRUE, right? Unexplained. So a detailed history and physical examining, and that is key in ALTEs and BRUEs, right? So in BRUEs, it is extremely important that you spend a good amount of time trying to get a detailed history and physical exam, because that's the key to your diagnosis and your management plan that you're going to make. So if no explanation is got on your detailed history and physical, you don't think this is a seizure, you don't think this is something cardiac, you didn't think this was GERD, this was not choking, this is not something related to non-accidental trauma, right? Then you're going to classify it as a BRUE, right? And of course, we know what the clinical symptoms constellation was initially. It was the same thing that we used to say with ALTE. So this kid did present though at home with change in color, change in tone, maybe altered, change in respiration. So all of this, if none of this fits, then it's called a BRUE, right? A brief, resolved, unexplained event. Now, what is more important is risk stratification, because you could still have a kid that looks absolutely fine, right? But might have something that's going on, something that's dangerous. So to go one step further then, once you do have this kid that you diagnosed with a BRUE, you have no clue what's going on. You can't kind of put your finger on any one diagnosis. You got to figure out if this kid is in the low risk or the high risk group, right? And a low risk group is any kid that is more than 2 months old, kid that's not premature, born after, say, maybe a little premature, more than 32 weeks of gestation, and definitely more than 45 weeks post-conceptional age. If this was only a one-time event, if no CPR was given by EMS, by paramedics, right, and there's nothing concerning on the history and physical exam, that kid can be classified as a low-risk patient. Right? And the reason they want to classify these patients as low risk, and we'll talk about this as management, because it has a lot of huge implication on the kind of management that you're going to give, right? So far, everybody with me, what the term ALTE was, why did we change to BRUE, and in terms of BRUE, what does it really mean, and how to classify it as either high risk or low risk. Are you okay? Yep, go for it.
One question I have is, like, when it says the event is less than 1 minute, is there a prompt return back to baseline, or do they define that event as now stopped? So, for instance, if the patient had hypertonia lasting like 45 seconds or so, but then was like confused or staring off, or had like a gaze that mom is saying was abnormal, does that still fit in that classification?
It does not. It does not. It means that the patient should be completely back to baseline.
So not even before it comes to ED, but all the way back?
Within a minute should be back. And I mean, most of you in the ED have come across a history that sounds like this, right? The mom was, and most of the time it's something to do with choking, gagging, and turning red or turning stiff, right? And the kid is totally fine, looks absolutely normal when you see them. So that's what you mean by a resolved event. All right. Okay. So let's talk about the constellation of symptoms, not BRUE per se, right? Because BRUE, by definition, should not have an answer, right? So when a kid comes in with this choking episode, stiffness, turning red, maybe apneic, right? Almost, I think 60 to 70% of the times, just on a really good history and physical exam, you should be able to figure out what is causing these symptoms. And in general, these are the most common causes for any of these symptoms, right? So most of them are GI, right? It's mostly because they were feeding, they overfed the kid, or they didn't burp the kid, and the kid suddenly started choking, turned a little stiff. Seizures, right? Again, neonatal seizures are more common, and it could be from a seizure-like episode that they got a little apneic, URI, RSV, pertussis, and in small number of cases, you could have something more. Something is more concerning, which could be like cardiac causes, inborn errors of metabolism, non-accidental trauma, something that you should always keep in mind, right? But for most of it, actually, and even if it is something benign or something more dangerous that needs further workup, you should be able to figure that out on your history and physical exam. And that's why it's extremely important that you spend those few extra minutes getting a detailed history on patients that come in with these kind of symptoms. Right. So what do you do, right? So I'm going to kind of talk about not only BRUE, but just patients that come in with these symptoms, right? So now you had this kid that was brought in by EMS because the child mom said was choking, turned a little limp and was red, and then turned a little cyanotic, and you bring the patient comes in. You look at the kid looks sick, right? You're going to stabilize this kid. This is not a BRUE. This is some sick that is sick. It may be sepsis, could be some kind of seizure, could be something inborn, but you're going to medically stabilize any kid that does not look well appearing. And that we all know, that's something knee-jerk. We do that all the time, right? But now you have this kid that comes in, is well appearing, right? Your next step is going to be try to figure out what's going on, right? So you're going to get a good history, good physical exam. You're going to focus on social histories, focus on other environmental things that could have precipitated some of these symptoms, right? And you're going to look at the vital signs. And after all this history, physical exam, vital signs, if everything appears, if you can come up with a diagnosis, oh, this is pertussis, or oh, this sounds like pertussis, this is bronchiolitis, or this is just a gagging, choking episode, again, you're going to treat that, and that you're going to do based on whatever. So if you think of just gagging, choking, you might just observe them, send them home. But you're not going to call those BRUEs, and you're going to treat the cause, right? The rest is all going to be categorized as a BRUE. So patients that are well appearing, good normal vital signs, and physical exam history is not suggestive of any one group. Okay? So now you have something which is a brief, resolved, unexplained event. And those are again classified as high risk and low risk. We already spoke about the classification. If the kid is older than 60 days, if the kid is not premature, more than 32 weeks gestation, more than 45 weeks post-conceptional age, one-time event, hasn't happened more than one, has only happened one time, has not received CPR in the field, right? Those patients are low risk. Now, for low-risk patients, there's a really good algorithm that has been put up by the AAP, and that's the only risk group that they say that they give some kind of guidelines of how to manage. And I don't know if you can see it, but basically what they say is, and so the main reason why these guidelines came up was because everybody was admitting anyone and everyone who came in with even a little hiccup, right? And there was a lot of blood tests being done, admissions, anxiety levels, costs. So they wanted to at least subcategorize the low risk. And they said, you know what, these kids are low risk. There's absolutely nothing going on with them. You took a really good history. You couldn't put your finger on anything. This kid looks great. Don't do anything, right? You can observe them, maybe in the ER, if you really feel that, no, you just don't want to send them home immediately. You can keep them in the ER for 4 hours. It's not unreasonable, right? Some people like to put a pulse ox to make sure that nothing's going on. Usually, I would say don't do that. Every kid transiently gets hypoxic somewhere, and it just causes a lot of anxiety and falsely negative results. A lot of us, and it's not unreasonable to at least get an EKG. And that's what you might have noticed. So well-appearing kid brought in, you can get an EKG. An EKG is important because sometimes they're really good in picking up maybe cardiac arrhythmia or something like that. It's not unreasonable to do an EKG. It's not unreasonable to observe them for 4 hours. In the meantime, you want to make sure they're able to drink, they have a good suck, they're tolerating their feeds, they're not having another episode, and then you can be more sure about sending them home. What they say is that please do not do a sepsis workup, don't do any blood work, there's no need for any imaging, there's no need for admitting them for the sole purpose of cardiopulmonary monitoring. Okay. Not really. You don't really need to, especially in a kid like this who just had this transient event, a BRUE, and it's a low-risk BRUE. Don't do anything. Maybe there's a low-risk recommendation, low-level recommendation of maybe observing them for 4 hours, and possibly if you want to do like EKG, or sometimes, some places, we don't do it that often, but you could do pertussis testing because pertussis is on the rise and it can come with a brief apneic episode, and then you have nothing else after that, right? So that's what you do for low risk, right?
One of the things that make you suspect because the really young kids don't always have.
Yeah, so it's based on a high degree of suspicion. So any kid less than a year, right? So how do kids present with pertussis, infants? I just said one thing. Apnea, right? And that's usually the only way they present. They cannot whoop, right? They don't have the kind of diaphragmatic muscle strength to whoop. So it's usually an apneic episode. So your history, if on history you find out that the mother was not immunized, was not given the DTaP during her antenatal visits, or they have somebody else that has come in, a family member that has been coughing a lot, whose immunization status you do not know. Those kind of, maybe on history, if you feel that could this kid have had this apneic episode from pertussis, maybe you can test it. You can test the kid. But that's what you would, those are the kind of questions you would ask. But it's all just a really, really high degree of suspicion. And most kids, if they're less than 6 months, 1 year, if you think that they do have pertussis, even if they look really good right there in the emergency room, you're going to admit them to the ICU because you don't know when the next event might be and how long the apneic episode might last.
Do you ever treat empirically?
I'm sorry?
Do you ever treat empirically with that?
You send the PCR or culture, and then you start them, yes. But in the setting of an ICU. Mm-hmm. Should I go on? So that was the low risk, right? Now, a BRUE, that is high risk. So a kid that had multiple episodes in a day. Kid that maybe had an apneic episode for 45 seconds. The EMS got there and felt that the kid didn't look all that great, or maybe they had to give maybe some chest compressions or something like that. That now comes to ED and looks good. Nothing on history and physical, but doesn't fit in the low risk category, is high risk. High risk kids you're going to treat however you think you think the direction they're going in. So if you're really suspicious of this kid having a seizure-like episode, or you thought this kid might have had a seizure, right? You're going to admit, you're going to figure out what you want to do. Do you need to do a sepsis workup? Does this kid need an LP? All that kind of stuff. So low-risk group, we know. High-risk breweries, use your clinical judgment, right? And everything else that could have been diagnosed, you're going to diagnose and treat accordingly. Right. Any questions? All right. So let's do a case. The mother brought in her 2-month-old with a bump on the forehead. She was in the bathroom when she heard a thud and noticed the baby had rolled out of the bed and fallen to the floor. On your physical exam, a small hematoma over the parietal region, but otherwise the kid looks absolutely normal, totally fine, vital signs are normal, and is just hanging out in the emergency room. What do you want to do? What do you think? Is this a BRUE or not? No. I'm sorry? Child abuse. Yes. Yes. So what made you think of non-accidental trauma?
Too young.
He's too young, right? So again, your history is going to be extremely important. And most cases of child abuse, you should be able to pick up just on your history and physical exam. So this kid is 2 months old. He's not turning around. You start rolling maybe at 5 months, 6 months, so there's no way a 2-month-old is going to fall off that bed, right? A change in a story, right? Dad says something else, mom says something else. Later on she changes. Oh, he fell from the crib. It wasn't the bed. It was 4 feet, not 2 feet. And this is extremely real. We see this all the time. And most of the times, it's a change in the story. There's always some different story that's being said. So good. So you've got to suspect non-accidental trauma. Extremely important. As pediatricians, we sometimes don't think of child abuse. As adult EM folks, it's probably even far back in the back of your head. So please think of child abuse. Almost, as per some reports, 10% of ALTEs, BRUEs could be from child abuse, right? The presentation of an ALTE, it could be from due to child abuse. So some of the things to look for if you have a kid with child abuse, right, on your exam. Look for these things: bruising, subconjunctival hemorrhages, bleeding from the mouth and nose. Usually, sometimes parents will smother with a pillow, so you'll find some bleeding within the nose. Head circumference suddenly is higher than 95th percentile. Bulging fontanelles, all of this indicating maybe some kind of intracranial hemorrhage, right? And of course bruising on the skin and things. So think of child abuse as one of the things that can present as a BRUE, right? All right. 6-month-old baby brought in by worried parents because he became stiff and then his face turned blue. Episode lasted 1 minute. In the ED, the infant is well appearing. Temperature is 104. Not a BRUE, right? You have an abnormal vital sign, not a BRUE. What could this be? Could be a febrile seizure, right? Could be a febrile seizure. It doesn't have to be tonic-clonic, but it could be anything, right? You're going to treat accordingly. You're going to do if you think that this kid is, in this case, he's well appearing. But if he wasn't, it could be sepsis or whatever, and you're going to do either full septic workup, start antibiotics, admit, all that kind of stuff. If it's a febrile seizure, you might send this kid home within a few hours, but it's still not considered a BRUE. All right, I'm going to go on to the next one, actually. Oh. Sorry. Can I play a video? Maybe it's taking. No, I embedded it, so it might be. Thanks, everybody sees that now.
While you're cheating notes. That's gonna work.
Okay, that's fine. That's okay. All right. So we'll just go back to the previous one. So it was, so this is the 11-month-old, bumped his head while playing, started crying. You went to comfort him, but then he looked very strange. It was as if he was trying to cry, but no sound was coming out of his mouth. Turned red. He made some choking noises. What do you think is going on? It's classic, seen very commonly. Breath holding spell. It can freak the parents out, right? Especially if it's the first time that, and not only parents, it can freak anyone out who hasn't ever seen a breath holding spell. And breath holding spells, though, occur in a slightly older age group. So it's more of like, 6 months to 24 months to 4 years, but you can see it in, like in the 11-month-old infants too. And unfortunately, the video is not playing. I can probably pull up another one. But they look like they're having a seizure. The body arcs completely. They turn blue, cyanotic. They stop breathing. They look like they're trying to cry, but no sounds are coming out. And a lot of times it's mistaken either for a seizure or for, like previously, an ALTE. So it's just something to really, if you get a good history of exactly what happened during the event, a lot of times parents have started taking videos of things like this. If you see it, it's a breath holding spell. It's not a BRUE. It's nothing to be concerned about. You can reassure them, and you can send them home. Right? It's not showing. Right. So I hope I was able to kind of just at least, this is a 30-minute lecture. I wasn't going to go into crazy details, but just wanted to at least make you guys comfortable with the terminology, what to do, what not to do, and take it from there. Whenever in doubt, whenever you're concerned about something doesn't sound right, but you can't put your finger on it really. You kind of, that it's just not, admit the kid. And you don't have to do blood work. You don't have to do, you don't have to go crazy. You don't have to do all this big sepsis workups and stuff like that. You don't have to get imaging done. But if it falls out of that range of a BRUE, it's always safe to admit these kids. Also, a lot of times in pediatrics, we follow the shared decision making, right? So we always speak to the parents and ask them, how they feel. And it's not unreasonable that if the parents are really, really scared and, they don't want to go home and they feel that this event was extremely, terrifying and, they're very anxious, admit the kid. Don't, there's no point thinking about whether this admission, was it valid or not, whether it's wasteful resources and money and healthcare costs and all that stuff. Because at the end of the day in pediatrics, you don't do this now. The mom's going to go home. She's going to come back an hour later, 2 hours later. She's going to go to another hospital, or she may not really come back at all. And you always include the family members when you make decisions of admitting patients, and we do that quite often. Actually.
What age did people stop at? Like, what age do you no longer consider a BRUE?
No longer consider?
What BRUE? Like, after what age?
1 year. So, sorry, I forgot to say that. So, one of the big changes in definition of ALTE and BRUE was they actually defined an age. So, they said it can only be in kids less than 1 year, right? And the other thing that they made a distinction is that, like I said, that it has to be a resolved event. So they cannot be going on. There can be nothing abnormal still going on. So usually kids less than 1 year. Any other questions?
Would you flu swab them?
So in flu season, so it depends. So if just like they had an apneic episode and came in, you could. It wouldn't be unreasonable, especially in flu season. We've recently had 2 kids, but these were with fevers, so it's not a BRUE at all. But we just had, in the last month, a couple of kids who came in with, a 1-month-old with a fever, and 1-month-old with fevers always get this whole sepsis workup, right? We flu tested them, and they were flu positive. Now, does that mean you don't do the whole sepsis workup? it's if you have a source, then you could possibly just get away with a partial sepsis work, at least urine and blood. You may not have to do a whole an LP and check for meningitis and stuff, but you can definitely flu swab them. Yeah.
But these kids are looking good, by definition.
Yes.
It's resolved.
Exactly.
So, how could it be sepsis or flu if they now look great?
So we've had most of the times, like I said, so flu, like I said, these kids came in with fevers, so it's not a BRUE, right? Now, if you had just a kid with just apnea who came in with a brief apneic episode, flu doesn't usually present that way. Pertussis definitely can present that way. So that's why I think more than flu testing, I think pertussis testing would make more sense. And that's why, two things: EKG, pertussis, maybe if you're really worried, and observing for 4 hours in the emergency room, making sure they're feeding, drinking, and there are no more episodes, and then you send them home. That would be reasonable. Cool. Thank you.